This is our last slide section. Woo, you guys made it through physiology almost. And you're like, I know what you're thinking. You're like, 22 slides. Easy peasy. Just wait. Just you wait. 27, sorry.
We knew how that went, so.
Exactly, yeah. So you guys are already, yeah, we'll see. We'll probably be here to like 1, 2, no big deal though, right? Okay. We're going to talk a little bit, this is probably inaccurate now, but we're going to talk about the autonomic nervous system. Wonderful glory. Okay, so if anyone gets to close that door, that'd be fantastic. That second class, man, they are just totally unprofessional. Just the worst. Anywho, don't tell them I said that though. They think I like them, so we'll leave it that way. Just kidding. They're fine. Okay, so looking at the organization of the autonomic nervous system, so we're going to find that this gets activated by several centers, both in the spinal cord, brainstem, and the hypothalamus. You'll also find that parts of that limbic cortex will also be sending signals as well. So again, the hypothalamus kind of helping out with that. And then we're going to have these visceral reflexes. So basically, one of the things you see, and we saw this especially with the GI tract. So remember that enteric nervous system that we saw with the GI tract? Unless you guys purged all those memories already. But there, I assure you there's an enteric nervous system. And basically, you can find that will send signals subconsciously, these sensory signals up through the autonomic ganglia. We'll talk about those in more detail. Through the brainstem, the hypothalamus, and then you'll have those signals kind of return back through. So if you remember, like that intestinal, not necessarily the intestinal, but more like the gastric phase of gastric secretion, right? So you could have signals that were coming from the stomach, getting transported up through to the brainstem and the lower parts of the brain. And then that signal will come back through something like the vagus nerve and will end up releasing, things like acetylcholine onto muscarinic receptors, right? So those are the reflexes that will happen there as well. We call those visceral reflexes because it's basically originating within the organ itself. And obviously our two main divisions of this will be the sympathetic and the parasympathetic nervous system. Yeah, we've already talked about this to death. We talk about it everywhere. I agree, but we're going to get some more details on this and specifically its function. And we'll talk a lot about receptors because I know everyone loves receptors. Okay, so anyway, so looking at the sympathetic nervous system, have you guys seen these kind of pictures before? And if you covered this in anatomy at all, you may do that at some point. But anywho, we'll cover it here. Basically, what we can see is that you're going to have two paravertebral sympathetic chains of ganglia that interconnect with the spinal nerves and the spinal column. So you can see them kind of coming off of here, and you have basically two chains of these paravertebral ganglia. Okay, so these are going to be called the prevertebral ganglia, and you're going to find these nerves going to extend from the ganglia to the internal organs. Okay, so you're going to have these chains. They're going to come off, and oftentimes you're going to run into these prevertebral ganglia, and then they're going to go over into the actual organs themselves. We'll talk more about specifically how those synapses are occurring, what's being released where they get activated. So one of the things that we see, again, we're going to talk about preganglionic and postganglionic sympathetic neurons, and because again, the transmission there and the neurotransmitters are going to be a little different. We're going to see that the cell body of the preganglionic neuron typically is going to lie in this intermediolateral horn of the spinal cord. So you can kind of see how it'll get started here, and we'll travel over into these chains here. So basically, once it gets to this point, there's kind of three paths that it can take. It can either synapse with the postganglionic sympathetic neurons within the ganglion. So you can kind of see here how it would synapse right at this point, and then the spinal nerve would travel out and be able to send whatever signal it is to either increase blood pressure or do whatever you need to do. You're going to find it could pass upward or downward in the chain and then synapse into other ganglia. So you can do that. Or you can find that, and you can see how that will travel down this point, and will synapse into another ganglia and then travel out to its kind of eventual organ. And then the other thing it could do is pass through the ganglion and synapse into a peripheral ganglion. And so you can kind of see this here where the initial preganglionic cell is coming in, traveling out through this peripheral ganglion, and then it will synapse at this point. Okay, then that can travel down, get to its effector. In this case, it might be the gut, and then also have sensory endings will kind of be traveling back up through the dorsal chain here. Okay, so it kind of makes sense about the different places. And it's important to know the difference between the preganglionic and postganglionic nerves because those are going to be functioning by sending out different neurotransmitters. So we'll see that there's a few differences here, though. Not everything is going to fall into these chains. We're going to find that some postganglionic fibers pass from the sympathetic chain through these gray rami into the spinal nerve. And so that is where we're going to see a lot of things like control of blood vessels, our sweat glands, and piloerector muscles get affected here. So you can kind of see these signals coming out directly where they are synapsing within the ganglion and travels out through something like the piloerector muscles. What do those do? Yeah, make your hair stands on end, essentially, or gives you goosebumps, right? And then also the blood vessels will be affected via this way, and then those are kind of the main things there. The sweat glands can also be affected here via that route as well. We'll also see that there's going to be some sympathetic nerve endings that actually goes directly to the adrenal medulla. So you can see basically right here how these nerves are going to be coming out, and they basically are going to run straight into the adrenal medulla, and that's going to release what? We're going to say epinephrine, norepi is going to end up being released from that adrenal gland there. So we'll talk about that in a little bit. Just note that both epi and norepi end up being released from the adrenal gland. Just note that it's probably much more going to be on the epi side. So usually that 80-20 split between epi and norepi ends up getting released from there. So on the flip side of that, we'll have the parasympathetic nervous system, and this tends to leave through cranial nerves 3, 7, 9, and 10. About 75% of it is going to be through that vagus nerve, right? So, and you can see here how these initial portions are going to be innervating pretty much the whole upper section of the parasympathetic nervous system. And then you'll also have some sacral nerves that will travel out, and they will synapse usually into the organ wall. Usually you're going to find that the preganglionic fibers will synapse close to the organ itself, and then the postganglionic nerve will kind of travel along the organ's surface, and we'll have these little varicosities that will release its neurotransmitter from. But you can see here, like, the lower portions of the intestine, anal sphincter, all those kind of things end up getting innervated through the sacral portions. We kind of mentioned some of these already in previous lectures. So, looking at secretion of the autonomic nervous system, we've looked at this picture previously, but cholinergic fibers. So cholinergic fibers is the term for anything that releases acetylcholine. And again, all of the preganglionic fibers are going to be cholinergic. So again, looking here at the autonomic, this is parasympathetic, this is sympathetic. All of the preganglionic fibers release acetylcholine. Those are going to affect what type of receptors? Nicotinic, right? So preganglionic fibers are always going to be nicotinic, okay? Because again, these are stimulatory. They're going to be releasing acetylcholine. Is going to trigger an action potential, and then we're going to see that will eventually signal the postganglionic fiber to release its neurotransmitter du jour. But basically, what you find with the adrenergic fibers, they typically end up releasing norepinephrine. Again, still here, all the preganglionic fibers are cholinergic. They're still releasing acetylcholine on those nicotinic receptors. But here, all the postganglionic fibers are going to be adrenergic. So for the parasympathetic nervous system, the postganglionic fibers release acetylcholine onto muscarinic receptors. Here for the sympathetic nervous system, we're going to find that norepinephrine gets released from the postganglionic terminals. Okay. Now again, you can see a few differences here. So for instance, with the sympathetic nervous system, you're going to find that really the nerve that innervates to the adrenal medulla is going to be releasing acetylcholine onto the nicotinic, through the nicotinic receptors, and that ends up releasing epi and norepi. So even though you don't really have that same kind of post and preganglionic setup as you do in the rest of the sympathetic nervous system, this is still going to be acetylcholine affecting release of epi and norepi, right? And so when you think about the difference between kind of the hormones coming out from the adrenal gland versus that being activated through the sympathetic nervous system, which one do you think has more kind of a long-lasting kind of effect? Usually the adrenal gland is going to have a little bit more long-lasting because it takes more time for it to clear from the blood, as opposed to the sympathetic nerve fibers. They're going to release norepinephrine, they get reuptaken or it gets metabolized, and it's very kind of quick, right? So it's much more of a kind of a fast response system versus it being released from the adrenal gland into the blood. It's going to be much more kind of slow type of effects, okay? All right, so again, most of the postganglionic fibers end up either, they don't just kind of terminate right in the organ wall. They typically kind of run along the walls of that, and they will release their neurotransmitters from these kind of varicosities along the tissues. That way they can kind of affect the organ in a whole rather than just kind of stimulating just one section of it, right? So that way you can innervate the whole thing, essentially. Again, here you'll notice that you can still have some muscarinic activity within the sympathetic nervous system, but normally this is only with your sweat glands, because again, we'll find that the muscarinic receptors are primarily going to be secretory in nature. We're going to find that it stimulates secretion of fluids and whatnot, and so this happens here when you have basically from this postganglionic fiber. This is the one exception where the postganglionic nerve is going to be releasing acetylcholine onto muscarinic receptors, and that helps to stimulate sweating, right? Because why do we want to sweat when we're in a sympathetic state? Yeah, get rid of body heat, right? Because we're going to be in a hypermetabolic state. We're going to be generating a lot of heat from the muscles. We want to get rid of that extra heat and evaporative cooling, so sweating helps us to do that. And so, again, when you're looking at receptors for the muscarinic side, again, I'm not going to get super granular on you guys knowing the difference between like M1, M2, M3, and M4. Just know in general, muscarinic receptors, right? They're going to be the effector receptors here. On the flip side of that, though, I do want you to know the difference between alpha 1, alpha 2, beta 1, beta 2. We're going to go through some tables, and that will become readily apparent. Now, the question is, why do I want you guys to know that? You may be thinking, this seems like useless information. What do I care if it's a beta or an alpha? The answer is drugs. Right? We use lots of drugs that affect the parasympathetic and sympathetic nervous system, and it's important to know side effects, know the mechanisms of their therapeutic effect. All these things are really important to know, and if you don't have a good understanding of the receptor pharmacology, you're not going to have an easy time remembering what the drugs do. Okay, and that's going to go into other disease states as well. So if you know that someone is producing too much catecholamines, you're going to know what those alpha effects are. You're going to know what those beta effects are. So it may not seem super important now, but you'll see how this will become absolutely critical when we get to pharmacology. Right? You're like, great, more farm stuff. But yeah, more farm stuff. Okay, so just again with the biosynthesis, we covered this a little bit already, but again, acetyl-CoA plus choline is going to make acetylcholine. That's via that choline acetyltransferase, and then gets broken down by acetylcholinesterase. So again, we're going to find that these are different targets for affecting these different systems. So for instance, if I inhibit acetylcholinesterase, what does that do to my acetylcholine levels? Should be elevated, right? So if I inhibit the metabolizing enzyme, you should have higher levels, and you're going to see certain effects from that. Again, choline gets recycled and can be taken back up into the presynaptic neuron in order to be put together with acetyl-CoA and get recycled. On the flip side of that, for your adrenergic stuff, you're going to see tyrosine gets converted as L-DOPA. This is actually really important for Parkinson's diseases. We'll cover that later on in pharm. But again, this turns into dopamine and then eventually norepinephrine. Now, 50 to 80% of that norepinephrine that gets released into the synapse gets reuptaken by those transporters. Remember, there's things that can affect that reuptake transporter and increase synaptic levels of norepinephrine. So think about drugs like cocaine or amphetamines. They can all do that. But as far as metabolism goes, you're going to have that catecholamine O-methyltransferase, or that COMT, and then monoamine oxidase, or MAO. And those are the primary metabolizers of norepinephrine, of epinephrine, dopamine. They all get metabolized by these two enzymes specifically. And then within the adrenal medulla, you're going to find that the norepi gets converted over into epinephrine, and that's going to be the primary release from that organ. Again, about an 80-20 split between epinephrine, 80% to 20% norepi, essentially. And we'll find there's a little bit of difference in balance between the effects that they're going to have, and I probably mentioned this before, but when you're looking at the alpha versus the beta effects, again, epi is going to be very kind of balanced between the two. You're going to see alpha and beta effects. With norepi, what you tend to see is more alpha effects, all right? And so that'll be important because we're going to look at the differences and how those might affect that sympathetic nervous system, okay? Okay, so looking at the receptor effects, typically what you see is that you can't just say, okay, well, muscarinic receptors are going to be excitatory, or sympathetic nervous receptors are going to be excitatory. It depends on the tissue you're dealing with and the type of receptors that you're hitting. So in some tissues, it's going to be excitatory, and other tissues will be inhibitory. You really just need to learn that based on the organ that you're dealing with or the tissue you're dealing with, what the effects are going to be based on alpha stimulation or beta stimulation or muscarinic stimulation. And so you'll learn that with practice, and also when we go through these tables in excruciating detail, you'll learn what these different effects are going to be and be able to predict, okay, well, if I have something that affects these muscarinic receptors, what am I going to see, right? What type of effects can I expect to see? So basically, you're going to find that they're either going to be innervating these ion channels, are going to be affecting these ion channels, or these metabotropic receptors. So primarily, you're going to find a lot of G proteins affecting things like CGMP or CAMP. Some of the cells are going to be affecting things like calcium influx or potassium efflux. You guys remember that vagal effect on the heart, how that usually slows or speeds up the heart? Usually slows it down, right? And that does that by releasing things like potassium from the cells and hyperpolarizes it, right? So think about those kind of activities. Typically, the cholinergic receptors, the main ones we're going to deal with are nicotinic. These are always going to be ligand-gated ion channels. So again, these are going to allow for inflow of things like sodium to allow for depolarization of the postganglionic fibers. And then you're going to have the muscarinic receptors, which are all going to be G proteins for the most part. Again, does anyone know what this plant is? It's tobacco. So that's where we actually get our nicotinic, is where we get nicotine from. That's how we were able to discover these nicotinic receptors based on the activities of nicotine there. So, and then anyone know what this is? It's a mushroom, right? Why am I showing a picture of a mushroom? It's because I'm a fun guy? No, this is actually the Amanita muscaria. So this actually contains a component called muscarine. Muscarinic is where we got the where we discovered the ability to activate muscarinic receptors. So that's basically where the names come from. Nicotinic comes from nicotine. Muscarinic was able to show us what the muscarinic receptors do. Again, if you ever wonder, certainly you can abuse this mushroom to get some very interesting highs. People use it for spiritual enlightenment, all kinds of things like that. So it kind of makes you look at Mario in a little bit different light, Anywho. So on the flip side of that, we have the adrenergic receptors. You're going to have the alpha 1 and 2 effects. These typically are going to activate different types of G proteins depending on what tissue it's in. And then beta 1, 2, and 3, again, they're going to be affecting different G proteins. For our purposes, we're going to focus on beta 1 and 2. 3, it gets used in some cases, but not frequently clinically, so we're not going to worry about that so much. Again, norepinephrine, you're going to find mainly going to be affecting alpha receptors, a little bit of beta effects, but primarily alpha. Epi is going to be more balanced between alpha and beta effects. Okay, so you can see that when we're looking at some of the clinical effects of these stimulation of these receptors, you can see what kind of different effects you can see there. Okay, so just to give you an example of what some of the different effects would look like between, say, like an alpha receptor and a beta receptor, right? So things like vasoconstriction. You have alpha activation, you see vasoconstriction, whereas on the other side, you can have vasodilation with the beta effects, right? So for instance, if I had a patient who's very hypotensive, maybe I wanted to give them something that's going to be more focused on the alpha effects. Maybe norepi might be a better drug to use in that case, right? Or maybe the patient needs to release more norepinephrine. Yes?
So you just have alpha receptor. If it doesn't have something next to it, do you assume it's all alpha receptors?
No, I'm going to show you another. This is just kind of just an example. I'm going to show you the actual detailed slides in just a few seconds here. I'll talk about that. It's easy to know. We're going to focus mainly on alpha 1 though for a lot of these effects. Okay, but we'll go into the tables in just a second. Anyway, so just other effects you can see. So iris dilation with alpha effects. You may not see any of those effects of the beta. The beta receptors. We'll look at things like cardio acceleration, all of these things. So there's very different effects based on alpha or beta stimulation, and so you can see different clinical effects based on like maybe drugs that have been patients been exposed to, all kinds of different things that will lead to different kind of clinical effects. Okay, so we're going to go through the different autonomic effects via organ system, and I will ask that you remember what the effects are of sympathetic and parasympathetic effects are on that organ. I will ask that you know specifically if it's an alpha or beta effect. For the sympathetic side, I will not ask you what type of muscarinic receptor it is though. Okay, I don't really care that you know that at this point. But beta and alpha effects are different enough that it's really important to know that for at least from a clinical standpoint. Okay? Does that seem fair? You're like, no, it's not really fair. But this is the rest of this lecture essentially, so we're going to cover all this good stuff. And again, you'll learn that as you practice this, and especially when you start to see drug effects in patients or different effects of these receptors, you're going to learn to kind of intrinsically, oh yeah, the patient looks like this. They have these different effects that are going on. This looks like alpha effects, or this looks like beta effects, or this looks like muscarinic effects. And so you'll learn that. And this is kind of going to be your first exposure to that. And so again, when we come up along drugs that affect these systems in pharm, and I go, oh, remember what alpha effects do? And you're going to say, yeah, absolutely, I remember it does this, 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 and this. Hopefully. Otherwise, hopefully, I purged all the information in the break between now and pharm. So anyway, so looking at the eyes first, the eyes can be a good portal, a good window, so to speak, into looking to see what kind of effects we could be seeing here in regards to the autonomic nervous system. So looking at things like the radial muscle, the sphincter muscle within the iris, ciliary muscles, and also the lacrimal glands, what you're going to find is that typically when you have more sympathetic stimulation, more effects from norepinephrine and epinephrine, you're typically going to see mydriasis, right? And imagine, just can kind of compare that fight or flight response versus the rest and digest kind of response. Fight or flight, you need to open up those pupils. You need to be able to let as much light in as possible so you can see what danger is coming at you, right? So kind of think about mydriasis causing that. So, so again, in the iris, in the ciliary muscle, again, this is going to be important for basically you'll see. Increased amount of secretions coming from the ciliary muscle, so you can end up seeing. I think it's got a little goofed up a little bit. This should be down one more slide. I'm going to fix that on the lecture. Basically, but what you're going to see is like for the iris, sphincter muscle of the iris, you're going to see like contraction. So you should end up seeing mydriasis for those. So remember, it's kind of pulling those muscles apart, pulling the iris apart, so that way you can let more light in. Typically, what you see for the ciliary muscle, because that affects the lens, right, is you're going to find relaxation of that. So again, it's going to achieve that more kind of flat kind of shape to it, and so you're going to be able to see things farther away, so you can see if danger's coming at you or that bear's running at you, whatever it happens to be. And then looking at the lacrimal glands, you'll typically see more secretion that happens there. So and typically what you're going to find is that contraction of smooth muscles is going to occur more from alpha effects, alpha 1 specifically, and beta 2 effects tend to cause smooth muscle relaxation. Okay, that's going to kind of be a general caveat. You're going to see that it will be predominant throughout the rest of this lecture, right? The only time we're really going to talk about alpha 2 is what I mentioned with that autoreceptor. You guys remember what autoreceptors are? Yeah, there's that negative feedback loop where basically when they get activated, they decrease the release of things like norepinephrine, right? So you're not going to see a ton of alpha 2 effects here coming up. So mainly the thing we're going to focus on is alpha 1 effects, right? And so we'll say this specifically. But anywho, so on the flip side of that, if you're looking at the parasympathetic effects, again, this is all through our muscarinic activation, you can see contraction of like the radial muscle, right? So you can end up seeing meiosis that can occur here. You're going to see for the sphincter muscle other contraction. I'm sorry, for the lens, you're going to see some contraction. So you can start to see things that are closer up, right? So you're going to cause bending of that light there. And as far as secretions go, again, you're going to find increased secretions due to muscarinic effects. In general, you're going to find that muscarinic effects are going to increase secretions just about everywhere. We'll talk about a mnemonic that will help us to remember those effects. But basically, if there is a mucous membrane or something that can release fluids, muscarinic receptor activation is going to help it out. Okay, so basically they're leaking everywhere.
Contraction for nerve vision supposed to also be with fluid?
That should be with the ciliary muscle. Yeah, I got a little goofed up. I was trying to edit this from a book chapter and it got goofed up. I'll fix it for the video. Any other questions? Okay. So just know, and so this is important because when I have a patient who comes in and say like they've been exposed to something like cocaine, which I know is stimulating the sympathetic nervous system, I look at their eyes, I expect to see big black saucers, right? So I can expect them to be mydriatic. And if I don't see that, that may lead me to think that, okay, maybe something else is going on here. Conversely, if I were to have, say, an anticholinergic affecting the muscarinic receptors, or so an antagonist blocking those effects, what would you expect to have happen to the eye? So if normally you would see meiosis occur with cholinergic effects, if I block that, you would see mydriasis, absolutely, right? And so what would you expect to see with the lens? Those muscles would relax and they would start to pull apart, so that's where they can have impaired accommodation. So again, when you think about going to the eye doctor and they dilate your eye, oftentimes they're giving you an anticholinergic. There's a drug called atropine that does that basically sits on those muscarinic receptors and prevents activation. So they can either give you an antimuscarinic that will do that, or they can give you a drug called phenylephrine that activates alpha receptors, and it kind of does a similar thing, right? So you can see here on either side, if I were to say, well, if I block these receptors, what would I expect to happen? Versus if I activate them, again, just the opposite is going to be occurring there. Does that make sense? Okay, so yeah, so those are the eye effects there. Next, looking at the heart, this is very, very important. Okay, so looking at the sinoatrial node, typically what you're going to find is that obviously the vagal effects are going to be inhibitory, the adrenergic effects are going to be stimulatory. And so what we see here is that primarily for the heart, specifically, beta 1 effects are going to be predominant, right? So when you think about beta blockers, the main thing they're going to be affecting is beta 1 receptors, especially when we talk about selective beta blockers. But the beta effects are going to be most predominant here, okay? Beta 2 effects are going to be more predominant, we'll see on the blood vessels, but here in the heart, it's beta 1. So for instance, the sinoatrial node, you're going to see increase in heart rate, right? The atria, you're going to see increase in contractility. In the AV node, you're going to see increase in automaticity, increased conduction velocity. The Purkinje system, you're going to see increased conduction velocity. In the ventricles, increased contractility, right? So all of these things, all these beta effects, primarily beta 1, is going to cause stimulation of the heart. So you can increase contractility, you're increasing heart rate, you're increasing cardiac output, right? Those are all good things for patients, especially if they have like, CHF and they're having poor ejection fraction out of the left ventricle. You can give them something that will stimulate that beta 1 effects, and that will cause the contractility to go up, and they'll keep getting out more and more blood, right? On the flip side of that, if I inhibited beta 1 effects, what would you expect to see? Bradycardia, decreased contractility, decreased cardiac output. So those could all be potential things that would happen if they had little beta 1 effects or reduced beta 1 effects, okay? On the other side of that, when we're looking at the parasympathetic side, typically what you're going to find is that the biggest thing the vagal effect is going to have, or biggest thing the muscarinic effect is going to have, is going to be specifically on heart rate and mainly affecting that AV node. You're not going to see as much effect on contractility, but certainly heart rate will be the biggest thing that gets affected by muscarinic effects. So if I were to give you too much activation of muscarinic receptors on the heart, what you would expect to see bradycardia, right? So you expect to see bradycardia, not necessarily decreased contractility quite so much, but certainly cardiac output will go down just by a feature of the heart not beating quite as fast, right? So, and on the flip side, if I gave you something that blocked the muscarinic receptors, what would you see? Tachycardia, yeah, you see increased heart rate, so heart rate would go up. So that's why if you have someone who is having a code or something, or they're bradycardic, and they're not perfusing the body very well, we'll give them a drug called atropine. So again, very similar to the eye, how we can give you atropine to the eye and cause mydriasis, I can give you atropine on the heart, and that will cause the heart rate to go up and cause, hopefully, either get you to a normal heart rate or you'll become tachycardic. Okay? Everyone with me so far? So think about the heart, think about beta-1 effects, think about that being stimulatory. On the other side, on the muscarinic side, think about muscarinic receptors causing decreased heart rate. Okay, not quite so much effect on the contractility. Moving on, look at the blood vessels. We're going to primarily see that there's not a lot of effect coming about from the parasympathetic side. So you really find that the parasympathetics do not have a ton of effect on blood vessel constriction or dilation. That's mainly going to be handled mostly by the sympathetic side of things. Okay. One thing you will see is that the muscarinic glands will increase blood flow to the salivary glands. Why do you think that is? Right, it's going to help stimulate, it's going to help with producing a lot of those salivary secretions. It's going to help with helping digesting of food and whatnot, right? So that kind of makes sense. But primarily what you're going to find is that the sympathetic effects are going to be the big thing here. This is going to be the important thing for affecting your arteries. It's going to be affecting coronary vessels, going to the blood flow to the skin, the skeletal muscle, all these things. So what we're going to look at is that typically the alpha-1 effects are going to cause vasoconstriction. Okay. You can find some alpha-2 effects a little bit, but that's not really the primary one here. The alpha-1 effects are going to be vasoconstrictive, and then for beta-2 is going to primarily cause vasodilation. So beta-2, think smooth muscle relaxation. Alpha-1, think smooth muscle constriction. Okay, so looking at the arteries and arterioles, alpha-1 is going to cause constriction. Beta-2 is going to cause dilation. Okay, think about the coronary vessels. Alpha-1 is going to be the primary thing. It's going to be constriction. Right? Look at the skin and the mucosa. You're going to find that alpha-1 effect is going to be causing constriction. That makes sense from that standpoint because, again, if you're in a fight or flight kind of response, do you necessarily need to perfuse the skin super well? You don't really care as much, right? You don't necessarily need to worry about that as much. We want to probably get blood flow going to other places like the muscle, as we'll see. But certainly beta-2 effects will dilate skeletal muscle. You're going to see a slight constriction, but typically when you're increased sympathetic effects, you don't necessarily want to impede blood flow going to the muscle. So you really see kind of very slight effects here. Usually you're kind of constricting elsewhere, like in the skin and other kind of accessory tissues to try to force more of that blood into the skeletal muscle. That's kind of the primary effect you'll see there. The cerebral is going to be the same. Pulmonary is going to be the same as well. So again, dilation with the beta-2 effects, constriction with the alpha effects. Again, it's going to stay pretty much the same all the way throughout. Okay, yes, ma'am.
Just what are the plus signs on
the? It's just kind of showing you relative effects. So if it has like 3 pluses, it's like that really caused some significant constriction. I'm not going to get that granular on the test. I will though ask questions like, okay, if I have increased alpha activation, what of these effects could happen, right? Which of the following would be true? You'll see decreased pulmonary blood flow. You'll say, and that's not right. You have increased constriction of the coronary vessels. You'll be like, oh yeah, that would be correct. So questions like that. So again, think about the blood vessels. Think primarily sympathetic effects. Think primarily is going to be alpha-1, primarily going to be constricting. Beta-2 is going to be vasorelaxing. Okay, so this comes up, and you're like, well, what does that matter? Right? It does come up though. So for instance, if I have a patient who has done a whole lot of cocaine, right? So the cocaine is going to increase the sympathetic effects in the body. So I can see a lot of alpha effects, and I can see a lot of beta effects. Okay, so that means the alpha-1 is getting activated quite a bit, beta-1, beta-2. And so based on the alpha effects, what do you think that does to, say, like his coronary blood flow? Probably decreases it, right? So he has all this alpha effects, basically he's clamping down on those vessels. His blood pressure is going sky high. So what does that put him at risk for having? Heart attack, right? So he can stop delivering as much oxygenated blood to the heart, and now all of a sudden he's having angina, he's having chest pain, he's having a heart attack now, right? And so one of the things they worry about is if you give them a beta blocker. Like one of the things you'll realize is, okay, well, I can give them a beta blocker to try to help out with the cardiac effects, because they're usually pretty tachycardic as well. One of the things they worry about is if you give a non-specific beta blocker, meaning it affects beta-1 and beta-2, that you would actually start to inhibit these beta-2 effects. And so at that point, if I block beta-2 effects, what does that do to blood pressure? should increase it, right? Because I'm not activating it anymore. So now I'm getting just unopposed alpha constriction. And now all of a sudden I've made that coronary blood flow even worse. Now the patient's having a worsened heart attack, right? So that's one of those things where it's like you can select specific drugs based on what you know kind of the effects are going on in those kind of situations, right? So in that case, I might use a different type of drug in order to try to get the patient's blood pressure and heart rate down as opposed to using something like a beta blocker. Okay, make sense? Hopefully. Again, go through repetition, kind of, and eventually you're going to get to a point where you can just think about this stuff and you just know, like, just I've looked at it so many times, okay, if I see a patient who's on cocaine, I know they're going to have increased heart rate, they're going to have increased blood pressure, they're going to have sweating, they're going to have X, Y, and Z occurring, they're going to have mydriasis. You'll just know what those kind of pictures look like, and that can be very, very useful, especially for us, like in the tox world. If you're trying to evaluate a patient who's maybe overdosed on something in the ER, this is very, very useful information to have kind of to know intrinsically, essentially. Looking at the effects on the lungs, primarily what you're going to see is that from the tracheal and bronchial smooth muscle, you're going to find that beta 1 typically is going to cause relaxation. I'm sorry, beta 2 is going to cause relaxation. I'm sorry about that. Again, think beta 2, think smooth muscle relaxation. So this is the same thing that happens here. And again, when I have someone who has an asthma attack, what drug do I give them? I'll give them albuterol, right? And albuterol does what? It's a bronchodilator because it affects what receptor? Beta 2, yeah. So if you ever heard beta 2 agonists, think albuterol, and that's what we're doing essentially. Someone's having too much bronchial constriction, they're impeding airflow during an asthma attack. I give them a beta 2 agonist, and that actually helps to relax that smooth muscle and open things up, and they can start to exchange air again. So that's a really big effect we are concerned about from the respiratory side. And then looking at the glands, you can also find that things like alpha-1 effects are not really super important here, but certainly beta-2 effects, you can end up seeing increased secretion, right? So that means having stimulation of secretion of mucus and things like that. Primarily on the flip side of that, if you're looking at the muscarinic side of things, you're going to see that this actually stimulates contraction of the smooth muscles. So that can actually induce an asthma attack in some cases. Or stimulation also will increase a lot of bronchial secretions as well. So for instance, if I'm trying to diagnose someone with asthma, one of the things I can do is to see how hyperreactive their bronchial smooth muscle is. And so I can give them a drug that actually activates these muscarinic receptors. And if they have a drop in their things like FEV1 and other kind of pulmonary function tests, you can say, okay, well, they're having this kind of increased response. I think they're probably asthmatic based on that. And then if you give them a beta 2 agonist and they get better because of that bronchial smooth muscle relaxation, then you have your answer essentially, right? So that's one of the things we'll do potentially to try to diagnose someone with asthma. Make sense? Okay, and again, just think muscarinic effects, think secretions everywhere. So they're going to have lots of like kind of bronchorrhea, which is going to be just kind of excess secretions in the lungs, and they're going to cough up all this nice thick mucus and stuff. It's not very good. Okay. Looking at the stomach, we're going to find that the muscarinic effects tend to be more predominant here in the stomach, and some adrenergic effects. But generally, what you're going to find is that the adrenergic effects, the sympathetic effects, are going to be decreasing tone and motility. Because again, if you're in a fight or flight response, you don't really need to worry about digesting a bunch of food. Okay, so that typically is going to be inhibitory. You typically will find contraction of the sphincters, because again, you don't need to necessarily have a lot of flow of things, say, from the stomach into the small intestine, etc. And typically you'll find inhibition of secretion. Okay, so again, generally inhibiting the digestive processes, versus on the flip side of that, you can have sympathetics, which are going to parasympathetics, which are going to be affecting those muscarinic receptors. You're going to see a lot of increase in motility and tone. You're going to see increased relaxation of the sphincter muscles, and generally secretions are going to be increased as well, right? So one of the things you run into, imagine if I had overstimulation of the muscarinic side of things, what do you think would happen? Well, if I had overstimulation of the muscarinic receptors? Diarrhea, yeah, absolutely. So that's one of the things you can see is defecation when you have overstimulation of those receptors. On the flip side of that, if I were to have, say, an anticholinergic, what could that lead to? Constipation, absolutely, yes. That's one of the things you run into with anticholinergics. You're decreasing secretion, decreasing tone, and peristalsis, and that can lead to constipation. So that can be one of the side effects you see with that, right? So again, think about what happens with stimulation. Think about what would happen if I block those effects, and you'll have a very good sense of kind of what will happen, especially with certain drug encounters, certain disease states. All these things you want to keep in mind. Okay, other effects on the intestine. Again, typically you're going to find that the adrenergic receptors are going to be primarily not causing stimulation of the GI tract, and inhibit peristalsis, inhibit secretions. The gallbladder will be more relaxed, as opposed to the muscarinic effects. You're generally going to see an increase in secretion, increase in motility, increase in contraction of things like the gallbladder, and the ducts, in order to increasing the release of things like bile salts and whatnot. Okay. But again, notice here, again, the beta-2 effects causes that relaxation. So even though you're in kind of a sympathetic state, you can relax that muscle due to that beta-2 effect causing smooth muscle relaxation. Okay. And if you look at the sphincters here, those are going to cause contraction, so they're going to predominantly show a lot of alpha-1 receptors, right? Yes, ma'am.
So you're saying if you stimulate the beta-2 adrenergic receptor, it will.
No, so if you imagine, like, what causes the gallbladder to expel the bile salts? You have to have contraction of it, right? So it contracts down, it's going to spit out those bile salts and can go through the biliary tract. So if I inhibit that, if it causes it to be more relaxed, I'm not going to be sending out as many of those bile salts, right? So in that case, if I constrict the sphincters with an alpha-1 agonist, right, or alpha effects, that's going to decrease the amount of food kind of traveling through the GI tract, and then I can also relax the gallbladder, not be sending out as many secretions from that standpoint. And again, just notice that if it's smooth muscle relaxation, primarily going to be the beta-2 effects there. You can see you guys are just as excited about this as I am. I kind of love this stuff. Okay, looking at the urinary tract. So here, what would you expect the muscarinic effects to be? Stimulatory or inhibitory? Yeah, generally stimulatory, right? So because again, muscarinic effects are going to cause us to need to urinate. So specifically looking at the renin secretion, you're going to find that the sympathetic effects can be kind of plus or minus here. Typically, you're going to find that the beta-1 effects tend to really increase renin secretion. Normally, renin is going to be more managed through things like the effects of the juxtaglomerular cells and whatnot. So you'll find there's kind of a tight control between the renin-angiotensin system and the sympathetic nervous system, but generally they kind of go hand in hand in some cases. The parasympathetic effects, and really no parts get affected by the kidney, but certainly you can end up seeing you don't see a lot of changes in renal blood flow or renal plasma flow and filtration due to sympathetic or parasympathetic effects, but certainly you're going to see big effects on urination to the urine's already been produced there. So typically in the bladder, for the adrenergic effects, we're going to see relaxation of the detrusor muscle with the beta-2 effects. So again, still seeing that beta-2 is going to be more smooth muscle relaxing. And then with the sphincter, you're going to cause contraction. That's usually that internal sphincter, right? So the alpha-1 effects are going to be constricting that. And in the ureter, we can see increased motility and tone by activating the alpha-1 effects there, right? Increase that tone so it prevents as much flow from coming through the ureters. On the other side, you can see this parasympathetic effects causing increased contraction of the detrusor muscle and increased relaxation of the sphincter, which will allow us to urinate, right? So that stimulation happens, and then the external urethral sphincter has to kind of combat that, and then until you get to a point where you can go to the bathroom effectively. On the sex organs, you're going to see that this is not going to be quite as important. Certainly for male sex organs, is going to be more important as far as like parasympathetic effects. We saw that was very important for causing erection, and then for the actual ejaculation phase, that's going to be more associated with the sympathetic nervous system. So you can see how there's going to be kind of an interplay between some of these for causing kind of sometimes they can be kind of not necessarily antagonistic, but sometimes they can be kind of synergistic in some cases. Here's here in the uterus, we can see relaxation through the beta-2 effects. And this is actually something we might do for a patient who's having kind of premature contractions. We can give them a beta-2 agonist, and it will actually help to relax that muscle and help to stop those premature contractions, right? So there's a drug called terbutaline that we'll sometimes use for that purpose. Again, variable effects from the muscarinic side, not a ton of innervation there, but normally you're going to find that the uterus tends to be more relaxed by the beta-2 effects. Alpha, not quite so important there. Next we have the skin. Typically alpha effects are going to be important for causing contraction of the piloerector muscles, and it will increase kind of localized secretion from sweat glands, right? So kind of increase just that kind of local effect. But for more kind of generalized sweating, you're going to see that's going to be primarily the muscarinic side of things. So as one of the things we look for, the patient who's having kind of too much muscarinic effects, they tend to be sweating kind of all over, even though their temperature might be okay. On the flip side of that, if I have an anticholinergic on board, the patient is going to look to be particularly dry, right? So they're going to look like, even though they may be very hyperthermic, they're not able to produce sweat because they're blocking those muscarinic receptors. And then on the miscellaneous side of things, typically what you're going to find is from the skeletal muscle that you're going to have primarily beta-2 effects in here. This actually helps to increase contractility. And also it's going to help us with glycogenolysis, which is good for energy production, which makes sense because if it's in a fight or flight response, you want to generate energy so we can run away from that bear or the alligator or whatever we're running away from at that moment. In the liver, you're going to see that primarily the sympathetic nervous system is helpful for inducing glycogenolysis and gluconeogenesis. Right, so this is very important again for energy production, getting blood glucose out into the bloodstream, so we can start to circulate that. For the pancreas effects, you're going to find that typically you're going to have decreased secretion from things like the pancreas due to alpha effects, although the beta-2 effects can actually help with things like insulin secretion and potentially glucagon in some cases. And primarily, again, secretion here is going to be stimulated by the muscarinic effects. Okay. So again, think about secretions, think about muscarinic effects. And again, we're going to try to summarize some of these at the end, so don't get too glazed over just yet. Yes, ma'am.
Why is it beta-2 for contractility of skeletal muscle?
Well,
I guess it's not smooth muscle, so it's a different.
Yeah, exactly. So you're doing the skeletal muscle. A lot of it has to do with that increased potassium uptake that helps to kind of get the cells a little bit more depolarized, right? So if increased potassium uptake, you're raising that electronegative, that resting membrane potential, and that makes it easier to trigger off that action potential there. Yep. And that's actually really important. Actually, that's a good point. Thank you for reminding me. Very smart of you. One of the things we actually do is that when you have a patient who has hyperkalemia, or what else would that? Yeah, high potassium. One of the things, and that can be potentially deadly because it can cause arrhythmias and whatnot. One of the things we'll actually do is we will give someone a beta-2 agonist, and that actually will help to stimulate uptake by that skeletal muscle of that potassium. So briefly, you can kind of draw potassium into the cells, drop the blood level, and that can help the heart to kind of stay in a stable rhythm for a longer period of time. So if you ever see someone with hyperkalemia, we give them albuterol. We mentioned that's a beta-2 agonist to help get that potassium into the cells, right? Again, for looking at the fat cells, typically you're going to see lipolysis and thermogenesis when you're having activation of the sympathetic nervous system. You see a lot of that with the beta-3 effects, but certainly any of these can be helpful here. And then typically you're going to find that the salivary glands are going to be usually not necessarily, you have a little bit of stimulation of the alpha effects, but primarily you're going to see a lot more effects here with the muscarinic effects. So again, think muscarine, think secretion of fluids, think the salivary glands as well. So again, and on the flip side of that, if you were to have blockade of those muscarinic receptors, what do you think that would do to secretions in the mouth? Would inhibit them, right? So they would complain of dry mouth, right? So that can be one of the things you can see if you were to take like Benadryl or something like that has anticholinergic effects. You can see dry mouth being a side effect of that. Okay, so some ways you can remember this stuff, right? Because again, that was a lot. But in general, if you kind of think about, okay, what's a fight or flight response? What do I want the body to do in a fight or flight response? That's going to kind of give you some clues as to kind of what to expect out of that patient. Or if I'm getting a rest and digest response, what do I expect to see? The things you can do to remember your cholinergic effects, a couple of mnemonics. You'll find that, especially if you talk about tox stuff, we love mnemonics because it helps us to remember lots of good things. We can divide out the cholinergic effects based on either their effects on nicotinic muscles or on muscarinic muscles. Or I'm sorry, nicotinic receptors or muscarinic receptors. So for the muscarinic effects, we're going to remember dumbbells. Has anyone ever heard of another mnemonic for this? Or heard of sludge? Sludge used to be the old mnemonic. Now we use dumbbells more frequently. It's a very good one to remember. So think defecation, right? Because we're stimulating the GI tract to increase peristalsis and motility. Think urination, bless you, because we're stimulating the detrusor muscle and inhibiting that internal urethral sphincter, right? Think meiosis, based on the basically relaxing those muscles within the eye there, causing meiosis. And then we have the killer bees, we call these, basically because these are the things that are probably going to kill the patient when you have way too much cholinergic activity. No one's ever going to urinate themselves to death, most likely. No one's going to poop themselves to death. But you can have so much fluid in the lungs that you stop oxygenation, right? So it's that bronchuria. You can have bradycardia to the point where you're not perfusing the body anymore. And so those are the things that can kill the patient. Bronchospasm. You saw the muscarinic effects causing smooth muscle contraction there in the lungs. Then you have emesis. So they'll typically have a lot of vomiting associated with muscarinic effects. Lacrimation. So you should have a lot of tears. And then salivation. So again, you'll be secreting a lot from the salivary glands. Okay. So again, think dumbbells, think cholinergic effects. Then on the flip side of that, if you're thinking anticholinergic, it would be basically the opposite of this. So you expect them to have constipation. You expect them to have urinary retention. You expect to see mydriasis. You expect them to have very clear lungs. You expect them to be tachycardic. You'd expect them to not have any vomiting, which is why sometimes we'll give anticholinergics for that purpose. They should have very dry secretions, dry mouth, not really having any tears. Probably will not be sweating very much either. Okay. So again, you can very easily kind of think about those as whether being stimulation of the cholinergic or muscarinic effects or blockade thereof. Make sense? Very good mnemonic to remember. So when you hear the dumbbells or hear sludge, and again, sludge is just, salivation, lacrimation, urination, defecation, emesis, but the dumbbells is nice because it includes kind of more of the things we're clinically concerned about killing that patient most immediately. All right, the other thing is going to be the nicotinic effects. And these are going to be by direct stimulation of nicotinic receptors, either preganglionically or in some cases on the postganglionic cells. Excuse me. Anywho, so I remember this by the days of the week, right? So if you think about it, we have Monday, and if you were stimulating, say, preganglionic, nicotinic effects on the eyes, before they really get to those sympathetic fibers, what could you see? You see mydriasis, right? So typically you're going to find this nicotinic effects being kind of more stimulatory. They look more like the kind of sympathetic effects. You can't see indirect activation thereof. We'll see tachycardia. So the patient would typically be tachycardic based on kind of pre-ganglionic stimulation of those sympathetic fibers. You can see weakness. Basically, this is going to be due to the neuromuscular effects we kind of talked about previously, to where if you remember, we said if we have overstimulation of those acetylcholine receptors, they can eventually fatigue out the receptors, and then it can lead to weakness, can lead to paralysis. That's one of the things we're also really worried about, and then paralysis specifically of the diaphragm, because if you paralyze the diaphragm, what happens? It's not breathing, right? So we don't want that. So that's one of the big things we worry about is that paralysis there. Next we have HERS day, or I guess Thursday. We'll say this is HERS day for hypertension. So typically you're going to see stimulation of smooth muscle constriction of the blood vessels, and then fasciculations. And what are fasciculations? It's kind of twitching muscle, abnormal kind of muscle contractions, and that's due to the initial stimulation of those nicotinic receptors on the muscles, but eventually they're going to tire out. Okay, so that's how we can remember the nicotinic effects of our muscarinic, our cholinergic drugs, or just cholinergic systems in general. Okay, so some other autonomic considerations. Again, just know that these fibers are not firing nearly as quickly as you would see in some other cases. So for instance, like skeletal fibers, in order to make sure I'm still standing, I need to be sending pretty constant axial potentials to keep these muscles in check. Usually they say 50 to 500 pulses a second. For the autonomic side, you really don't need as fast a transmission. So you may only need, say, 10 to 20 pulses per second in order to keep the autonomic function working appropriately. Looking at tone, so if you ever hear the term like sympathetic tone or parasympathetic tone, basically what that means is that at all times you're going to have some sympathetic outflow, and at all times you're going to have some parasympathetic outflow. You really want to keep those kind of in balance between one another, and you want to have room on either side to either decrease output or increase output. So for instance, if I was looking at like blood pressure, and I was dealing with the sympathetic nervous system, my blood pressure drops too low, what do I want to have happen? Vasoconstriction via what receptor? Alpha 1, right? And that could cause it to go up. Now, on the flip side of that, if it's hypertensive, I would expect that, okay, well, maybe I'm having too much sympathetic activation. If I was already at 0% sympathetic tone, I really have nowhere else to go, and I would just remain hypertensive. So that's why you kind of want to be set in the middle. You want to have some degree of outflow at all times, so that way I can decrease sympathetic outflow if I need to, or I can increase it, right? So that way you're kind of always set at, if you're imagining a scale of 1 to 10, you're always kind of at 5 essentially, and then that can kind of vacillate back and forth depending on what the situation kind of calls for. So, and then looking at those autonomic reflexes, just remember that those occur, those are visceral reflexes. So think about like the cardiovascular responses we can see. So for instance, if I were to have, say, decreased baroreceptor response in the blood vessels, what do you think that would do? So decreased baroreceptor response means there's too low or too high pressure? Too low pressure, and then what would be the response? I want to increase vasoconstriction. I want to increase cardiac output, so I'm going to be affecting the alpha receptors to cause vasoconstriction. I'm going to cause increased beta-1 effects on the heart to increase cardiac output. Those are, again, so think about those kind of responses of what's going to occur when you have changes thereof. And on the flip side of that, if I were to say have too much baroreceptor activity, there's too high a pressure, what could I do? I can vasodilate by decreasing alpha-1 activation. I could maybe decrease some of the cardiac output by decreasing the beta-1 effects, right? So think about these sort of things. Urination, like we saw the balance there between the alpha and the muscarinic effects. Once the bladder starts to fill up to a point, then I'm going to have those reflexes to say, hey, let's go ahead and we're at a point where we can urinate. Let's increase the pressure on that detrusor muscle, relax that internal urethral sphincter, and then based on the conscious control, the external, you can have urination that can occur. So you kind of think about these effects, think about kind of what the reflexes are going to be in those situations. Okay. So again, looking at the CNS control of the autonomic nervous system, we're going to see that the sensory input basically gets, during these reflexes and things like that, you're going to have that sensory input sent to the brain centers. And again, you're going to find that primarily the hypothalamus is going to be one of the major regulator here. This helps with that body temperature, helps with our hunger, our thirst, our pituitary gland especially. And then the limbic system, I don't know why that went out. Going to pretend. You can always watch the video if you need to. Okay, so anyway, so we mentioned the hypothalamus, what that's going to be controlling. Also that limbic system, and this is going to be helpful for certain autonomic responses, say like with emotional states. So imagine if you are become very embarrassed all of a sudden, or you're very nervous about something. What do you think is the autonomic response? Is it the sympathetic or parasympathetic? Mostly sympathetic, right? So if I was like very nervous about talking to you guys, or I'm like, all of a sudden I'm very nervous because like the projector just went out, what kind of responses would you expect to see, right? So heart rate, what did you expect to have happen? Should increase. Blood pressure should increase. What's going to happen to my skin? Start sweating, right? I'm getting really nervous. I'm starting to sweat. I'm going to feel very hot. Like, so all those things kind of help get managed through the limbic system, because again, that controls behavior, that controls some of the autonomic responses to that. Sometimes you get this kind of cold sweat. Some of it's related to like vasoconstriction, but you're still sweating at the same time. So sometimes you can experience some of that. But those are the basic things. Also, the brainstem will be important for this as well. So especially with certain things like the respiratory center being affected by the brainstem, some of the cardiac effects being all stimulated through there. But you can see how it's kind of a unique balance between the two to make sure that we are managing both sympathetic and parasympathetic, because it can be kind of go haywire on either side of things. Okay, so next slide. So ways that we can affect the system, right? So this kind of gets me into my little pharmacy diatribe. But imagine things like sympathomimetics. When I say sympathomimetics, what do you think that means to you? They mimic the sympathetic nervous system, right? So these are going to be things that kind of cause an increased sympathetic tone because they are kind of either mimicking the effects by directly activating those receptors. So some things will activate alpha-1 receptors, some things will activate beta-2 receptors, or they could just be doing things like increasing the concentrations of some of these neurotransmitters at the synapse. So imagine if I give something like dopamine or norepinephrine, those would directly activate things like beta receptors or alpha receptors. So because they're mimicking the effects of the sympathetic nervous system, that's why they get that name sympathomimetics. Some things can increase that release of norepinephrine from the nerve endings. So we mentioned cocaine, amphetamines. Everyone ever heard of ephedrine? That's kind of a drug we don't really use too much anymore, but it used to be a vasoconstrictor and used to be good for patients who are having a cold, right? And so they're getting a lot of like nasal stuffiness and stuff. And we can give them something like ephedrine because it would vasoconstrict the nasal mucosa, and all of a sudden you have so much edema happening there, right? So think about things like that. Certainly you can block the activity of certain drugs getting to the receptor. So like for the sympathetic side, you think about things like beta blockers. You think about things like alpha blockers. And so you can kind of intrinsically know, well, if I block alpha-1 receptors, what's going to happen? What would you expect to happen to blood pressure? Should go down, right? So that's why we can use alpha-1 blockers to help reduce blood pressure, right? You can also see like effects on the urinary tract. So like sometimes we'll give alpha blockers to patients with BPH or benign prostatic hyperplasia, because that actually helps to relax the prostate, right? And that allows for better urine flow. Certainly you can do things like clonidine, which are actually going to be agonists, but it's an agonist at the autoreceptor. So in that case, it's an alpha-2 agonist that by doing that, by causing that negative feedback loop to be activated, you decrease release of a lot of those sympathetic catecholamines and whatnot. Okay. On the other side, when you have the cholinergics, you can do several things here. One, you can inhibit the ability for acetylcholinesterase to metabolize acetylcholine. So if I have an acetylcholinesterase inhibitor on board, what do you think that does to the muscarinic effects? Should increase it, right? So that's why when I talk about those organophosphates, they block the effects of acetylcholinesterase, and it causes increased release or increased activity of acetylcholine. So you can see all those muscarinic effects. So when you have a patient who had accidentally been exposed to that, they're having tons of secretions everywhere. They've urinated all over themselves. They've defecated. They're having excessive sweating. So you know all those effects and why that's consistent with these cholinergic activity. Certainly, we have plenty of antimuscarinic drugs, which means that those are going to be, and that's an important distinction there, because when you have antimuscarinic activity, that means it's sitting on muscarinic receptors. That's going to be decreasing the effects specifically of those dumbbells I mentioned, right? Versus if I were to have something that affects the nicotinic receptors, what do you think that would cause? We have a nicotinic receptor blocker. Think about those paralytics I mentioned, right? So now you got to incorporate things like the neuromuscular junction. So when I give something that blocks nicotinic receptors, now all of a sudden I have a paralyzed patient, right? That's a lot different than giving like Benadryl just for your to try to dry you out. But if I give you something that affects nicotinic receptors, now you're not breathing, right? So kind of think about these effects and kind of keep them compartmentalized. And like if I activate it, what happens? And if I block it, what can happen? And then also things like stimulation of postganglionic fibers, like things like nicotine, can be interesting here because again, if I activate those the postganglionic cells, that can increase stimulation of parasympathetic and sympathetic nervous system. So that's why those nicotinic effects. You can see things like tachycardia. You can see things like the mydriasis because you were stimulating indirectly the sympathetic nervous system. That makes sense? So again, just be aware of what receptors are responsible for those main effects. And again, if I drew particular attention to it, that's probably a good thing to know for testing purposes, right? Be aware that the cholinergics are generally going to stimulate secretion. Know that alpha-1 effects are typically going to constrict smooth muscles. Beta-2 effects typically going to relax smooth muscles. Okay. That is it. Any questions? That's not too bad. Just an hour. About 55 minutes. Well, that's it for physiology. That's all of our material. Congratulations. We made it. We did it together. It's my first time. Hopefully it wasn't the worst time. We'll see. See on the review. So again, I appreciate honest feedback. If you think that, hey, this section was terrible, like, what can I do to make it better? For farm, I'm an expert at that, so don't tell me what. I'm just kidding. No. On any of this stuff, we can always use constructive feedback. So I really encourage you to be honest. If you thought it sucked, tell me. That's the only way I'm going to get better. Other than that, we'll do the review next week, and then the test is on Friday, correct? All right, and then that'll be done for physio, and we're done for this semester. I'm very happy to be done right now. I'm very tired. So, any other questions? Okay, I'll see you guys later.